Welcome to the deep dive. Today, we're really zeroing in on something critical, especially for you medical professionals getting ready for board exams. We're talking about the nuts and bolts of managing acute toxicological emergencies. We've gathered some solid materials, and our mission today is basically to pull out the absolute must-know info for you.
Absolutely. And, when you look at how to approach a poisoned patient, our sources kind of break it down into three main buckets.
Okay.
There's supportive care, which is huge, then the specific treatment for whatever the poison is, and finally what's called complementary management.
Right.
We'll touch on all three, but the key thing, the absolute first step, is always stabilizing that patient.
Okay, so stabilization first. Let's unpack that. One of our sources talks about the ABCD of toxicology.
Yeah, that's fundamental.
It builds on the standard ABCs, but really tailors it, right?
Yeah.
Prioritizing airway, breathing, circulation, and neurological status. That's your immediate checklist.
Exactly right. Those are the immediate life threats. Your first moves have got to be about shoring those up. So maybe let's dive into respiratory compromise first. That comes up a lot.
Sounds good. Yeah. So respiratory arrest, obviously that's about as critical as it gets in toxits.
It really is.
And the sources point out it can happen in a few ways. You might get direct depression of the brain's breathing center, like heroin overdose is the classic example. Yeah.
That's a big one. Or it could be muscle weakness. The muscles just can't do the work of breathing anymore. Or even just, a physical blockage in the airway.
And it's not just full arrest we need to worry about. Respiratory insufficiency is also really common.
Definitely. The materials mention several ways this shows up. Hypoventilation is one, just not breathing enough, deep enough, or fast enough. Or maybe they're not getting enough oxygen in the air they breathe, or the gas exchange in the lungs isn't working right. Could even be problems with oxygen transport in the blood or the tissues actually using the oxygen. Often it's kind of a mix of these things.
And the common thread, the sources say, is always going to be needing oxygen therapy.
Oxygen is always part of the plan, yeah. But you also have to make sure that oxygen can actually get where it needs to go. So keeping the airway open is just paramount.
Right. Basic stuff first. Head tilt, chin lift. Unless you're worried about trauma, then it's the modified jaw thrust, obviously.
Exactly. And suctioning out secretions, maybe using McGill forceps if you can see something blocking the airway, like a pill fragment or something.
And for the more serious cases, if someone's got depressed consciousness or you're worried about aspiration,
then you're likely looking at endotracheal intubation. And using Sellick's maneuver, that cricoid pressure during intubation, is often recommended to help prevent aspiration.
Okay.
And what's interesting, specific to tox, is the mention of using rocuronium, a paralytic sometimes. Say in cocaine or organophosphate poisoning, it can really help facilitate getting that tubed in safely.
Gotcha. Now, what about isolated respiratory arrest? Breathing stops, but the heart's still going.
Yeah, the support vital source covers that. Bag valve mask ventilation is key there. Just got to be careful not to hyperventilate them. Keep things steady.
And antidotes come into play here too, right? If you suspect opioids or benzos.
Oh, absolutely. If you strongly suspect an opioid, naloxone can be life-saving. Same with flumazenol for benzodiazepines, though you use that one a bit more cautiously.
Right. And monitoring ventilation.
Capnography. It's really become standard of care, gives you that continuous feedback on how well you're ventilating the patient. It's super useful.
Makes sense. And opioid overdose is mentioned as a really frequent cause of arrest.
It is. It's unfortunately very common. The AA guidelines even suggest lay people can give naloxone IM or intranasal if they suspect an opioid OD in someone with a pulse but not breathing.
Yep.
And this is a huge but, that doesn't replace calling 911 and starting standard resuscitation. It's just one piece, an early piece, hopefully.
Understood. Okay, let's switch gears a bit to hemodynamic instability. Cardiorespiratory arrest is the worst case scenario here.
Yep. The end of the line if we can't intervene effectively. And toxins can cause it directly, poisoning the heart muscle itself.
Or indirectly.
Exactly, like profound lack of oxygen from that respiratory arrest we just talked about. Or maybe severe electrolyte problems triggered by the toxin, leading to deadly arrhythmias.
So standard CPR stuff applies compressions, maybe electrical therapy.
For sure, those are the basics. But the sources make a really critical point for toxicology. You have to think about the specific toxic cause simultaneously.
Right. Treating the underlying problem.
That might be the only way you get them back. Antidotes during the code, for example.
And before full arrest, there's shock. That's the severe compromise leading up to it.
Right. And shock isn't just one thing, is it? You've got hypovolemic, distributive, cardiogenic, obstructive.
And toxins can cause any of those.
Pretty much, yeah. So your treatment has to match the type of shock and ideally the specific toxin involved. It gets complex.
Also see less severe stuff like just hypotension or hypertension from substance use.
Yeah, orthostatic hypotension when they get dizzy standing up. Or the opposite, really high blood pressure, especially with stimulants. That can be an emergency itself.
And arrhythmias, of course. Fast heart rates, slow heart rates.
Yeah.
Both can cause big problems.
Definitely destabilizing. And another one, especially in younger folks using stimulants, is acute coronary syndrome.
Like a heart attack.
Essentially, yeah. Cocaine, for example, is notorious for causing coronary artery vasospasm. The arteries clamp down. It's a real danger.
Okay, so back to CPR and these toxic arrests. High-quality compressions are key.
Absolutely non-negotiable. Good rate, good depth, letting the chest fully recoil between compressions and keeping interruptions minimal, just like any code.
But there's a twist for tox, isn't there, about duration?
Yes, exactly. For certain poisonings, like, say, calcium channel blocker overdose, you might need to do CPR for much longer than usual.
How is that?
Because the toxin's effects might be reversible with time and specific treatments, like antidotes or other supportive measures. So you don't give up as quickly, potentially.
Interesting. Okay, what about defibrillation? Shockable rhythms like VTach, VFib.
Early defibrillation is just as crucial. The source mentions starting biphasic shocks at 150 joules or higher. And if it's unstable VTach, but they still have a pulse, synchronized cardioversion is the way to go.
And the non-shockable ones, a systole, PEA.
Then your focus really shifts hard to finding and fixing underlying causes. This is where the H's and T's mnemonic comes in handy.
And toxins is one of the T's.
Bingo. Which points you towards thinking about specific antidotes right there in the code. Like anti-digoxin antibodies if you suspect digoxin toxicity, or hydroxycobalamin for cyanide.
And again, potentially prolonged resuscitation efforts might be warranted here too.
Correct. If there's a chance the toxin effect is reversible, you keep going longer than you might otherwise.
Okay, and the last piece of that initial ABCD assessment, neurological function.
Right. You've got to assess their level of consciousness immediately. Are they altered, confused, comatose? Are they seizing? Are they severely agitated? These are all neurological emergencies needing rapid support.
So once we've tackled those immediate ABCDs, the life threats, with supportive care, then we move to more specific treatments.
Exactly. And that often happens kind of parallel, doesn't it? While you're supporting them, you're also thinking about, okay, how do we deal with the poison itself?
And the sources mentioned 3 main strategies there.
Yeah, broadly.
Yeah.
Decreasing absorption, maybe activated charcoal if it's appropriate and early, or skin decontamination. Then increasing elimination, things like dialysis in some cases. And finally, using specific antidotes if one exists and is indicated.
Got it. And beyond directly treating the patient and the poison, there's this complementary management idea. What falls under that?
Well, first off, protecting ourselves. Personal protective equipment is crucial, especially if you don't know what you're dealing with or if there's a risk of contamination.
Good point.
Then there's the aftermath, potentially, need for psychiatric evaluation, involvement of police if it looks like foul play, forensic medicine if, sadly, the patient doesn't survive. And often, these patients need ongoing care in the ICU. And don't forget associated conditions caused by the poisoning. Things like rhabdomyolysis, muscle breakdown, or severe allergic reactions, anaphylaxis.
Okay.
And there are specific syndromes linked to psych meds like neuroleptic malignant syndrome or serotonin syndrome, acute dystonias. Those need recognition and specific management too.
Wow. Okay. So it's a really wide scope. As we start thinking about wrapping this part up, let's distill it down for exam prep. What are the absolute must-know takeaways?
Okay, number 1, without a doubt, ABCs first. Assessment and stabilization always come first. That's bedrock.
Non-negotiable.
Second, understand that supportive care and toxicology can be a bit different. Think about that potentially prolonged CPR for certain toxins and the fact that you might actually give specific antidotes during resuscitation efforts, which isn't typical for all codes.
Right, those tox-specific nuances. And recognizing patterns.
Huge. Learn your toxidromes. Those symptom clusters, like anticholinergic, cholinergic, opioid, sedative, hypnotic, sympathomimetic, they give you massive clues about what you might be dealing with and guide your next steps, including which antidotes to consider.
Speaking of which, knowing the key antidotes is essential, yeah.
Oh, absolutely critical for exams and practice. Naloxone for opioids, flumazenil for benzos, atropine for organophosphate scarpaments, digoxin-specific antibodies, hydroxycobalamin for cyanide, know those cold.
And understanding shock the types and how to initially manage each one when a toxin might be the cause.
Definitely. You need that framework. And tied to that, managing hypertensive emergencies from stimulants like cocaine or amphetamines. Know that benzos are often first line there.
And crucially, what not to give.
Yes. Big pitfall. Avoid beta blockers like propranolol and cocaine toxicity. That risk of unopposed alpha stimulation is real and dangerous.
Okay, what about arrhythmias?
Know the initial go-to drugs, maybe lidocaine for stable monomorphic VT, magnesium for torsades de pointes, but also know the contraindications, again, avoiding certain drugs like beta blockers or even calcium channel blockers in specific tox situations where they could make things worse.
Got it. And managing altered consciousness or coma.
Be systematic. Remember, the coma cocktail idea is largely outdated and potentially risky. Focus on supportive care, glucose check, ruling out other non-toxic causes like head injury or infection.
Years.
Know the common toxic causes and that benzodiazepines are usually your first-line treatment.
And finally, the agitated patient.
Safety first for everyone. Try verbal de-escalation, but be ready with physical restraints if needed. And pharmacological options, often benzos again, maybe antipsychotics, but always try to tailor it to the likely cause of the agitation if you can figure it out.
Okay, that's a lot, but really practical. So the bottom line seems to be needing a really systematic approach, but also being ready to adapt based on a specific toxin and how the patient responds.
That's it, exactly. You integrate that immediate life support with the specific toxicological knowledge you've been talking about. It's a constant interplay.
So to leave our listeners with something to really think about, especially as you study this complex area, given all the different ways toxins can mess with the body's basic functions, what do you see as the single most challenging part of managing these cases when you're in the thick of it, in a high-pressure emergency setting? Something to mull over. Thanks for joining us for this deep dive.